Welcome everybody to this EU-IPFF webinar on genetics in ILD, genotypes, phenotypes and the future, which is the third in a series of monthly webinars leading up to the European Pulmonary Fibrosis Patient Summit in April 2021. My name is Steve Jones. I'm the president of EU-IPFF, the European Pulmonary Fibrosis Federation, which is made up of 21 pulmonary fibrosis groups from across 15 countries in Europe. And I'm also the chair of the UK organisation Action for Pulmonary Fibrosis. As many of you know, we had hoped to hold a webinar, a patient summit in Poland, in Warsaw, in April this year. But because of the pandemic, we had to postpone it. And we've decided now that we're going to hold that meeting as a virtual meeting on the 23rd to the 25th of April. And you're all very welcome to register to take part. We were disappointed to cancel the meeting at very short notice in Warsaw because we had a great program planned with lots of exciting speakers and events. However, I'm pleased to say that we've got two of those speakers with us tonight who would have been talking in Warsaw. It gives me great pleasure to introduce Dr. Raphaël Borie from the Hôpital Bichat Claude-Bernard in Paris, who is one of the leading researchers on interstitial lung diseases in Europe. Raphaël tells me that he used to be a keen rugby player, so congratulations on the win against Italy at the weekend, but you still have to face Wales. Les Gallois arrivent, huh? Our second speaker is Professor Coline van Moorsel, a microbiologist from St. Antonius ILD Center of Excellence and the University of Medical Center in Utrecht in the Netherlands, who, like Raphaël, specializes in the genetics of ILD. Coline did her PhD on snails and tells me that she keeps many snails at home. Now, I'm sure there's a joke somewhere in here about a Frenchman and snails, but I won't make it anyway. Our speakers will each talk for 15 minutes, which we'll follow by 20 minutes of Q&A. We aim to finish tonight by 8 o'clock. European time, 7 o'clock UK time. Could I please ask you to submit any questions you would like to ask using the Q&A button, which you'll find at the bottom of your screen. Please do not use the chat function. Don't use the chat function, use the Q&A function. When you submit your questions, could you please write complete questions and make them as succinct as possible so that you don't clog up the system. We don't want any general comments, just specific questions. If there turns out to be too many questions to answer tonight, Raphaël and Coline have kindly offered to provide written responses afterwards, and these will be available on our website. The webinar tonight will be recorded and will be available on our EU-IPFF website in English and 5 other languages with subtitles. I think that's everything. So without further ado, it gives me great pleasure to welcome Dr. Raphaël Borie and invite him to talk to us on the genetics of pulmonary fibrosis. Thanks very much indeed, Raphaël.
Thanks a lot, Steve. I'm pleased to discuss about the pulmonary fibrosis of genetic origin today. I would have been pleased to discuss in front of you in Brussels, though I'll do my best to do it today on the way. Okay. So what are the evidence for genetic predisposition of pulmonary fibrosis? The first evidence for that is that we have a lot of families with several cases of interstitial lung disease. Probably almost 10% of the patients with idiopathic pulmonary fibrosis also report a relative with interstitial lung disease. We don't have any conceptual definition to the diagnosis of familial pulmonary fibrosis. Should we limit the definition to 2 or 3 degrees of relationships? Should we limit the definition to idiopathic pulmonary fibrosis or to secondary interstitial lung disease? However, whatever the definition, it suggests a genetic background to the disease. The second point is that we also have evidence for a heterogeneous presentation of those diseases. Indeed, in almost half of the family, the cases are heterogeneous. in 2/3 of the patient will present unclassifiable pulmonary fibrosis compared to patients with a classical UIP pattern, what we usually see in patients with idiopathic pulmonary fibrosis. So we are also add evidence for the last 20 years that in the same families, we may have some patients with a diagnosis of idiopathic pulmonary fibrosis and some other patients with unclassifiable fibrosis or other interstitial lung disease. So we may discuss all those diagnoses all together when we offer a genetic analysis. And the second point, in almost 60% of the families, we have several generations with interstitial lung disease, suggesting an autosomal dominant transmission of the disease. I'll go into genetic in a few seconds. Whatever the tool we are using, whatever the performance of them, for a maximum of 40% of the families, we are currently able to offer a genetic counseling or a gene associated with the diagnosis of pulmonary fibrosis. And as you can see on this graph, there are a lot of genes. So I'm not going into details in each of these genes. However, we can summarize all these genes in 3 different groups of genes. Indeed, if we have a familial case of pulmonary fibrosis, in almost 1/3 of this family, we are going to evidence telomeres-related gene mutation, less frequently in surfactant-related genes. However, most of the genes are evidenced in children and are really rare in adults, and other syndromes are super rare. And for most of the families, we are not going to evidence any genetic abnormalities. I'm going to talk a little bit about telomeres. This can be a little bit scary to see this graph because it's going to be like a lot of genes, a lot of proteins, and we don't know at all what's going on. But I'm going to talk a little bit about it just to introduce what are the telomeres, just to understand what are the telomeres. Our genomes are is located on the chromosomes, and at the end of the chromosomes, all of us have this region called telomeres. And we need for our life to rebuild the telomeres to protect our genomes and our chromosomes. And to rebuild these telomeres, we need a lot of proteins that are involved to rebuild the telomeres. And when one of the genes doesn't work, when there is a genetic abnormality, then one of these proteins is not going to work and the telomeres are going to shorten. When it doesn't work, they may be associated with different kinds of disease. The first one is pulmonary fibrosis and idiopathic pulmonary fibrosis. However, those genetic abnormalities may also be associated with other diseases, such as hematological disease, hepatic disease, and more rarely, skin disease. That's why when we see patients with familial cases of pulmonary fibrosis, we ask them if they have any hematological or hepatic disease that may be suggestive on one of these genetic abnormalities. Going back to our first question, familial case of pulmonary fibrosis, when we are able to offer a genetic analysis that is not available in every country, almost 20% of the families will present a mutation with one of these genes. However, when we have other clues for the genetic abnormalities, this prevalence may increase. Indeed, if the patient presents extrapulmonary signs such as hematological or hepatic disease, or if in the same family we have the same, we call it phenotype, hematological or hepatic disease, then the prevalence of mutation is increased above 50%. Accordingly, without those signs, the prevalence of mutation decreases. The last important point when we discuss about genetic analysis and the risk or the chance to evidence genetic abnormalities, the age is super important. Let's say it differently. When we have two brothers and sisters or two siblings above the age of 70, then the risk or the chance to evidence a mutation is pretty low. However, the younger the patient are, the higher the risk to evidence abnormalities are. Indeed, below the age of 60, the prevalence of mutation is increased. Below the age of 40, we don't have so much telomere-related gene mutation, but we're going to have and we're going to show some different mutations. Does it change something for the diagnosis? It doesn't change so much, and we may see a lot of different kind of ILD. Most frequently, idiopathic pulmonary fibrosis, which is a more prevalent idiopathic interstitial pneumonia, but we can also evidence unclassifiable fibrosis, and we also are able to see secondary interstitial lung disease, such as connective tissue disease and rheumatoid arthritis ILD in patients, or also hypersensitivity pneumonitis. Indeed, there are a lot of evidence to show that there are a lot of genes and environment interaction. We know for sure that smoking and lung exposure may induce pulmonary fibrosis or induce exacerbation of pulmonary fibrosis. And it is also true for patient carriers of telomere-related gene mutation. In two different cohorts, the prevalence of smoker and the patient with evident lung exposition were super high, between 70 and 80%. So we may act on this important point. Secondly, we know that some patients may also present liver disease. And again, the increased consumption of alcohol is associated with an increased risk of cirrhosis. And lastly, it was an important point for our patients, for those patients that may present a risk of hematological toxicity of hematological disease. The use of cytotoxic drugs, and particularly after lung transplantation, may induce several cytotoxicity, including platelet toxicity. So we should avoid cytotoxic drugs such as azathioprine. However, does currently available anti-fibrotic therapy works in patients with those mutations? The answer is yes. We have two important trials showing that anti-fibrotic therapy are effective in those patients, and more importantly, they are not associated with a different side effect compared to a patient with sporadic idiopathic pulmonary fibrosis. Can we offer a specific therapy for patient carrier of this mutation? Because we know the cause of the disease. So maybe we would be able to offer a specific therapy. So we have some clues suggesting that a specific therapy could target the genetic abnormalities. And this trial was done in America by the NIH, and they were able to show that the danazol, a synthetic androgen, was able to increase the telomere length, and that was associated for the 2 years duration of the trial with no decline of FVC, really stable FVC. That's why we are currently running a phase 2 clinical trial currently in France dedicated to patients with those specific mutation, and we're going to have some results pretty soon. Unfortunately, some patients may need lung transplantation, and we need to be really careful for those patients of hematological risk and to avoid some cytotoxic drug. But when we do so, we are able to have pretty good results of lung transplantation. I'm not going to talk a lot about lung transplantation and its specific issue, but regarding the hematological toxicity, when we are able to specifically take care of it, we have pretty good results comparable to what we have in idiopathic pulmonary fibrosis. And I will finish with this slide. What are our current indications for genetic analysis? This is a French proposal. We offer a genetic analysis for patients with familial cases of pulmonary fibrosis. We also offer genetic analysis for patients with short telomere syndrome, including liver, lung, and hematological disease, and also for patients below the age of 50 with idiopathic fibrosis. We are currently running with Coline task force dedicated to this question. And we also need your point on this question because Coline is running a dedicated survey for patient and relative to get your input on that question. I thank you for your attention.
Great. Raphaël, thank you very much indeed for a very interesting paper, and we'll come back with questions after Coline's talk. So Coline, over to you, please, on the future of the genetics of pulmonary fibrosis. Before you start, could I just say to people, please put your questions into the Q&A button at the bottom, and we'll have them ready then for the Q&A session at the end of Coline's talk. So thank you very much, Raphaël, and over to you, Coline.
Thank you very much, Steve, for this nice introduction. I'm going to talk about three subjects: the ERAS task force, the survey we're currently running, and future perspectives on genetics in ILD. Let me first. The task force. Sorry, the task force is a group of people, and we have one task, and that is to provide a statement on genetic testing in pulmonary fibrosis. We're going to summarize evidence for which patient may be tested, even family members that may be tested, how counseling should be performed, and which genes or exit test may be may provide information, and about a natural history of the disease, so how disease developed, and a follow-up and therapy in patients with familial pulmonary fibrosis. Now, Raphaël and me have a special interest in monogenic ILD, all the other members too, but they also have different specialisms like a pediatrician, a genetic counselor, and a patient representative. And they also represent different other societies in the European Union. So I think we will have a well-founded statement at the end. Well, the benefits of genetic testing seem obvious because normally genetic testing helps you to get a diagnosis. It provides a prognosis. It can aid a decision for which therapy and which therapy is safe for you. And it can also inform you for decisions on life planning. However, in this case, and particularly in the short telomere syndromes, it's really, really complicated. And I'm going to take you along some research we did, and we're going to encounter all these complicated decisions that we have to make while interpreting the results of testing. Well, this is a patient, and she has a brother, and both show signs of short telomere syndromes because they have pulmonary fibrosis, which is the blue part here. They have bone marrow abnormalities both, and they have liver cirrhosis. And Raphaël has been telling you about how these associate with short telomere syndromes. However, we only have DNA from this female person, and she provided informed consent that we can test her DNA and we can look at her medical charts for her disease. Now, if you look at DNA of people, the results are not as easy to understand because we have 3 billion nucleotides in a certain sequence that determine the way we look, the way our metabolism works, but not necessarily which diseases we get. We also have 3 million nucleotide variants, and these are mostly neutral. They can tell us the color of our eyes, maybe the kind of things we can taste, but they don't associate with diseases. So what is a pathogenic change? How can you find it? Well, first of all, you can look at the position in the genome and at a particular gene. However, this is already complicated for pulmonary fibrosis. And here I show you an online repository of all Mendelian diseases, so diseases where mutations in a certain gene can cause the disease. And if you put in pulmonary fibrosis, you get over 5,000 answers. And this is the reason why family members that go to different doctors and with different labs at the background, which perform different tests in different genes, they get different results. Well, in fact, they may carry the same mutation, but we're not all looking at the same genes. So as a task force, we're going to list the genes that are really associated with pulmonary fibrosis, and we group them for telomere-related genes, surfactant-related genes, and others associated with syndromes in ILD. So if we know the genes and we find a mutation there, for instance here, Raphaël has been telling you about the third gene, which is coding for the enzyme telomerase and very important for cells. We find a mutation, but what does it mean? And this is a study where they looked at 60,000 individuals, and they found that over half of the mutations they found were unique and only carried by one person. So, and these persons were not ill. They didn't associate with any illness. So what is a pathogenic change? Well, we could predict the quality or the quantity of the enzyme, which may change with the mutation. And in this case, this mutation causes a change in the enzymes, and it makes the enzyme dysfunctional. Now, this is a computer prediction, so it's not enough for us to say this is really a pathogenic change. What happens when your telomeres don't function? Well, this is a picture of 2 cells in a normal lung. This is one cell, and this is another cell. And this cell is green. And if it's green, we know it's an alveolar type 2 cell. And we also colored the, apart from the DNA, which is blue here, we also colored the telomeres in the cells. And you see here the telomeric ends in the DNA. So there are multiple points. They're in this alveolar type 2 cell, and they're in the other cell. Now, if you look at a patient with IPF, you still do see these telomeres in other cells, but you don't see them anymore in type 2 cells. So they're absent or they're very weak. So this is critical shortening of telomeres, and it causes fibrogenesis. Now, to see all this, we could do experiments, but they're very laborious, they're time consuming, so they don't provide easy answers. We could also look at phenotype of other carriers. And we're a small sized country, and we have an ILD biobank for over 15 years now. And we have over 1,000 patients with pulmonary fibrosis in our biobank. So we thought, let's look if this mutation also occurs in other people in our biobank, because if so, and it's enough people, then we can say the mutation is associated with pulmonary fibrosis and probably causal to the disease. Now, we have 1,000 people with pulmonary fibrosis. We match them with 1,200 people with ILD without pulmonary fibrosis, and we looked for the mutation in all of these over 2,000 individuals. There were none in the patients with ILD without pulmonary fibrosis, but there were 13 in unrelated patients with pulmonary fibrosis. So what you see here is that there was one in a family with pulmonary fibrosis, one in a family with bone marrow failure and pulmonary fibrosis, but also several that were in isolated patients, which were not part of families with telomere disease. So this already shows that it's complicated who should who we can expect to have mutations in genes that cause pulmonary fibrosis. Now, because they were all from one part of the Netherlands, we asked a medical clinical genealogist to see whether these people are related. And he looked up in all these old church repositories of names, marriages, birth certificates, and he found that 4 of these families were related to each other, and they had a common ancestor over 300 years ago. And this shows that it's really, really complicated to interpret what's going on here. Because if the mutation exists here and everybody in this tree has to carry this mutation, and they're really old when they die, so here, and this person has a mutation, they're over 80, this one, and this one, they all have a mutation, no sign of telomere disease. What's happening? Because this generation, they're in their 50s, 60s, and 70s when they get telomere disease. So what's happening here is that the telomeres shorten with each generation, and that means a lot, and it makes it very difficult to say whether a mutation is already pathogenic or not. Because it means that not all carriers get the disease. For instance, these parents, they didn't have the disease. But also probably not all non-carriers will have normal telomere lengths, because these telomeres shorten with each generation. What's happening in this person? If this female had a son, she transmits her short telomeres to the son. And even if she doesn't transmit the mutation, we don't know if he's predisposed to develop disease or not. So that's really, really complicated. We also have to define, as Raphaël said, what is familial disease? Is it only pulmonary fibrosis, like here? Or is it ILD, like here? Because this person has sarcoidosis, but she did not carry the mutation. So I think we shouldn't say familial ILD. Is it short telomere syndromes, like here, where maybe if he only had bone marrow failure, we would still call it familial disease? Should you take into account lung cancer or any other aging diseases, or even 1st degree, 2nd degree, 3rd degree, or over here, like it's something like 8th degree related. So that makes it very complicated. The benefits of testing in a patient are quite clear, but the benefits of testing the relatives, that's more complicated. Normally, you would identify a subject that's at risk, and you can screening for early diagnosis, early intervention. But now we think all relatives are at risk for the telomerase mutations. So what we offer these patients is a physical screening with lung function, HRCT, so that's imaging of the lungs, a physical examination, and questions about their health status and their complaints. And there's also, of course, risks associated with testing and going through physical screening. The psychological burden, there's uncertainty about what will be the results of your screening. You may have some insurance problems for life insurances. And I'm very pleased to say that, well, it fell off, but this is a very recent study. And what they looked at is they looked at whether people regretted taking part of a screening program where they tested for genetic abnormalities and physical screening for pulmonary abnormalities. And they saw that 91% did not regret taking part in this screening program. But, and even if they found a genetic variant that predisposed the participants to disease, people didn't really regret taking part of the program. However, if they were lower than normal lung function, or if they had seen abnormalities on the HRCT, so imaging, then people did more often regret taking part in the program. So people have to really realize that there can be adverse outcomes from screening. And you have to talk about that with your physician and your counselor. And that is also why we need you. We're developing all over Europe, we're developing these programs, but what are your perceptions? What are your experiences, and what are your needs? And that's why we developed a survey on genetics in ILD. So not only patients with pulmonary fibrosis, but for everybody with ILD, and also for the family members of these patients. There are about 30 to 40 questions in this survey about diagnosis, familial disease, genetic test, information and screening. And it's not about what you know, it's about what you want to know or about what happened to you. So follow this link, just type this link in your browser, and then it will bring you to this screen. It's a blue screen. And the first question is about in what language you want to take this survey. We have them in 7 different languages, and you can take the language you prefer. It's already quite successful. It's going all over the world. Patients and relatives have answered the question and completed it 600 times already. So everybody can only fill it in once. But we would always like more, and we especially encourage relatives to take the survey. And also pulmonologists all over the world really answered the questions. So we're pleased with it. The survey is running only this month still. So you have to complete it before the 1st of March. And then we're going to analyze the results, and we will share with you what comes out. Now, a very short part about the future of genetics in pulmonary fibrosis. As Raphaël said, we can detect mutations in around 40% of patients with familial disease. And if they don't have familial disease, the percentage is really, really low. Well, that means that we're missing a lot of information. So either it's not genetic and it's more or less environmental, or we don't know enough about the genetics forms of the diseases. So what we need is a way to detect early disease, because if we can detect early disease, then we're not so much dependent on the results of genetic analysis, but we can still help a lot of relatives and patients. So why do we want to detect a disease much earlier? Well, because if people get symptoms, they already lost a lot of their lung function. So the people that come into the clinic on average, and that is worldwide, it's everywhere the same, they lost over 40% of their lung function already, and the average is about 50%. So you're very far in the disease already. So what we would like to do is to have a marker to find people much, much earlier at the start of disease. Because you can imagine that if you start therapy much earlier, that you have much more time for an intervention that is maybe successful. So how will this, how can we find such a marker is, and that's also why we need you to take part in screening programs if you think that will provide you with valuable answers. And if we're gathering the information from screening programs, which will evaluate the status of your lungs and your health, then we maybe find an easy and early disease marker. And if we look good enough, like with proteomics or other assays, I think we can find a marker that can also be brought to your general practitioner. So you don't have to visit the hospital each year or every 5 years, but you will only have to visit the hospital when there are early signs of disease. So with an easy and early disease marker and with genetic testing, I think we will go forward towards targeted therapy. So for instance, if you have a surfactant mutation, you will have drugs that will counterbalance the surfactant mutation. But if you have a telomerase mutation, you will drugs that will help keeping your telomeres at a good length. And if you have very early disease and there's early fibrogenesis, there may be drugs for this early to counter affect the early fibrogenesis. Now, if we can do this and we start very early with an intervention, I think we can make survival much better. So Raphaël showed you this disastrous pictures of not so good survival in patients with familial disease. But if we're earlier and we have more time to intervene, I think we can save a lot of lung function. So the last slide, I was talking about genetics in pulmonary fibrosis. It is complicated, and that's why we have a task force. We will provide a framework for its current use with a survey, and I call on everybody to complete the survey, the patients and the relatives. I think in the future with screening, we will develop an early disease marker and if possible, an easy one. And together with genetic testing, we can start to use targeted therapy, which partly has to be developed yet, but at least if we can find these patients early, we can also start very early with trials. Thank you very much.
Great. Thank you very much indeed, Coline and Raphaël before. So Raphaël, if you'd like to come back on with your camera, that would be great. And we'll start kick off with the questions. As I said before, questions, please, using the Q&A button at the bottom of your screen. Can I ask a question to start with? I mean, excuse the ignorance of my terminology, but what is the difference between, we hear sometimes in the UK about the difference between genetic mutations and genetic variations. Can you clarify what the difference is?
Please, Coline.
Can I do that?
Yeah, please.
Okay. There is not a real difference. A variant is everything that can vary. A mutation is, well, it is the same, but we use the word mutation more often when we think it's very rare and when it causes disease. So a variant is not often disease causing, and a mutation sounds a little worse. But in fact, the words are synonymous.
Okay. So it's not a question of a genetic mutation being something which is definitely inheritable and a genetic variation being something which might possibly be inheritable.
No, it's not about inheritance. It's about like all mutations in your genome, in germline of your genome, they are inheritable. There's a difference with the mutations that we find in, for instance, lung cancer, because these are so-called somatic mutations and they only occur in the tumor, so they're not heritable. But the mutations we've been talking about are heritable mutations.
But then if, I think you said at the beginning, or Raphaël said at the beginning, maybe 10% of pulmonary fibrosis patients have familial. I mean, I know different people give different figures, but 10, 15% have familial PF. But those of us, and I'm not absolutely sure which group I fall into, but those of us who have sporadic pulmonary fibrosis, the non-familial, we still have genetic variations, and those genetic variations still possibly cause disease, and they may be. Well, you see my difficulty.
Yes, I'm going to ask you this question if you agree. So the first point is, before being familial, the pulmonary fibrosis is sporadic. So first case of the family is sporadic, whatever the family. So it's really an often situation like, oh, my brother had a pulmonary fibrosis. So then the second patient is then the familial case of pulmonary fibrosis. So according to the definition of the timeline, then the prevalence of familial case of pulmonary fibrosis may differ. For instance, in the French cohort of idiopathic pulmonary fibrosis, at diagnosis, the prevalence was 8%, and 5 years later, the prevalence was 12%. That's why it may differ. It may vary from one survey to another, one cohort to another. So we don't have to be so strict on this definition.
Okay, but a patient with sporadic can inherit their genetic variation.
So the second point is some of the sporadic case of pulmonary fibrosis may also present genetic abnormalities or genetic mutations. So what are the indications for genetic analysis? Because you can't offer genetic analysis for the whole population of idiopathic pulmonary fibrosis. So that's why all the phenotype and the age of the patient are also important clues for the prevalence of genetic mutation. That's why after the age of 70, the prevalence of mutation or the prevalence of genetic abnormalities are rare. It's not zero, but it's lower. So just according to different kind of indications, the prevalence of genetic abnormalities may vary.
Okay, we have a question here. Are the treatments for the future of surfactant mutations, and what are the treatments rather, and is there an evidence base for those treatments?
We don't have so much evidence currently for those super rare patients because we don't have so many trials ongoing. So what we have comes from Coline, for instance, because she was one of the first to evidence surfactant mutation in adult cases of pulmonary fibrosis. And we also have some data from our colleagues caring about children. And some of the children were improved with steroids, hydroxychloroquine, or macrolides, such as azithromycin. But we don't know for sure if they may be effective for adult patients.
Okay. I mean, an overall question that comes out in a number of these questions and ones that were sent to us ahead of time is, what is the balance between genetics and environmental triggers? I mean, one person once explained it to me as being...
Yeah, that's a very interesting one. I think in patients with really disease-causing mutations, these are incredibly penetrant, which means that nearly everybody with a mutation get a disease. In surfactant disease, this is really nearly 100%, and you don't need environmental insults to your lungs to cause the disease. In telomere mutations, you see that, as Raphaël has been showing, that smoking and other toxic insults to your lung, they can either accelerate the disease or they can cause the disease. And with telomeropathies, we think that smoking may cause pulmonary fibrosis, but if you drink a lot, you may get liver disease. So there is a combination, but for patients with familial disease, and if they carry a mutation, then the mutation is much stronger, so much more predisposing to disease than environmental contribution.
Okay, so would it be true then to say, if you had a continuum from the most familial through to the most sporadic, that the people at the end of most sporadic are people who will primarily need a huge trigger, probably need a bigger environmental trigger to get disease than is the case with familial?
Exactly.
That is a logical way to think about it?
Yeah.
Okay, sorry, I'm obviously, this is like genetics 101 for me. I'm learning as we talk. Another question that came in from a friend who's may or may not be here. I'm not sure if she managed to make it tonight, but her mother sadly passed away with pulmonary fibrosis, and she's been diagnosed with disease at an earlier age than her mother, and I believe her mother in her turn was diagnosed earlier than her mother. Is that common with familial pulmonary fibrosis? Is it called anticipation or?
Yeah, shall I ask? Yes, that is called anticipation, and it's a feature of short telomere syndromes, and it's I'm sorry to have to explain this, because I think it's really terrible what's happening there, is that with each generation your telomeres get shorter, and you do not only inherit the mutation, but you also inherit the shorter telomeres. And with each generation, they become shorter and shorter. And so this means that somebody, the mother gets ill when she's 90, the next generation get the disease when they're 75, and the next generation when they're 50. But the speed of this decelerating age when you get ill depends on the severity of the mutation. So there are very mild mutations that do not really speed up. So then the difference is only 5 to 10 years. And there are very severe mutations that speed up a lot. And the father is around 60 and his child around 30. And that's a different story. And I think, Raphaël, you did a study with ERTL1 mutations which don't go that fast, I think.
Yes, there's also a lot of difficulty to interpret data, and there's a lot of differences between genes, and probably within the genes, some of the mutation may be associated with the risk of anticipation and some of the less. So it's really complicated, as Coline said before. And so, yes, we can have anticipation. Some family may experience this terrible news, but we also have to be careful before giving that information, as it may really differ from one patient and one family to another. And we hope that we may have some treatment, and probably some patients also have some specific modifications that may interfere with this risk.
Okay, that's interesting. You talked about genetic counseling or genetic testing being done for people with familial, with short telomeres, and with fibrosis, and they're less than 50 years of age. So it's about patients fitting that profile, yeah? Was what the situation in France, I think, was.
Yes, so we have genetic counselor just to discuss about it with families and patients before offering any genetic analysis. And I will answer to some of the questions according to the country. The possibilities are really different. So Coline and I have almost the same practice, and we are offering a lot of genetic analysis to our patients, but some countries are not able to offer any genetic analysis. So it's really, also we need your input on that, because if the families and patients are prone to this possibility, then we will be able to offer more and more genetic analysis. And according to one lab to another, then the possibilities are different to other. That's why we need your advice and your point of view.
So if you have clear familial fibrosis in your family, I mean, you may want to get your children tested early. Is there any value in that?
So it's important. It was really an important slide showed by Coline. Most of the relatives want to know their own status. So it's really, and according to the country, the laws are really different. In France, when we evidence the genetic abnormalities, when we have to offer to the relatives the possibility to do the genetic analysis. So it's really, we have to, as physician, we have to offer that possibility. So it's really the relatives and the children that comes to our facility and ask for the analysis. So this is a law in France. And at least we can offer them to avoid toxicity, and we hope to be able to offer them more than that.
Yeah, I know somebody I once met who had that as a teenager, said that they kind of, a bit like your 91%, Coline, you know, they probably were basically happy, but it has certainly, they said, colored their life in a sense. You know, they knew things earlier than they would otherwise have known them. And no, they weren't 100% sure that it was positive. So clearly there's a really strong role for genetic counselling here. Yeah? I should say, just for UK people, in Britain so far, genetic testing has only, I think, been available generally as part of research projects and on a somewhat sort of, you know, not everywhere all the time, where the Brompton Hospital is putting in a proposal with Partnership with Action for Pulmonary Fibrosis to try and get that changed with the NHS so that it becomes more readily available for, you know, all patients fitting certain criteria. So the situation hopefully is getting better in the UK. One person asked whether the early marker trials that you mentioned are likely to be carried out in the UK. Do you know? Or?
Well, I think all over the world there are early marker trials running, and not only trials, also just I suppose Raphaël is also running services like that with physiological screening of patients. And what we do is we do the screening, but we also collect samples so to investigate if this can be done easier. Because what we see, and that's also an insurance thing, is we ask people who carry a mutation or have familial or a relative of a patient with familial disease. We ask them if they want to have pulmonary screening. They come to the hospital every year for evaluation. And if they are evaluated, it's in a hospital, and it costs them always over 350 euros. And they feel good, they are healthy. And if you start at 20 and you get the disease when you're 60, you have 40 years of these screening activities. So it costs a lot, and you don't feel every time you're excited about the results. So we see people doing that once or twice and then leaving us, and then they come back after 5 years and they have the disease and they're too far. So we don't want to miss out. So I think we need to go to a very simple marker, and where they don't have to visit us anymore, but can go to their general practitioner or send some blood tube somewhere, or go through other types of something very simple. I think that would really be very helpful.
That's great. But from your graph, or from one of the charts I think that Raphaël showed early on, the vast majority of supposed genetic mutations can't be identified at the moment.
Yeah.
Yeah. So even if you have genetic testing, it's not necessarily going to give you an answer.
Yeah, that's important to know for all the patients and all the families, that for most of them, we are not going to be able to evidence any genetic abnormalities.
Yeah, because that came up in 2 or 3 questions here. There is another one, the heterogeneity point you talked about early on. The idea that a family can have familial, 4 members of a family have familial pulmonary fibrosis, but have different types of pulmonary fibrosis. So do we understand anything of the genetics underpinning that?
The idea is that probably the genetic associate with other kind of risk factor. And when we first began working on that, some of our colleagues told us that we were not, we should not include a patient with secondary ILD, and you probably know some patient with rheumatoid arthritis associated ILD. And what we saw is that the genetic background was almost similar between rheumatoid arthritis associated with interstitial lung disease and idiopathic pulmonary fibrosis. So the idea is, again, as well as for environmental risk factor, those risk factors, and Coline made a great study with asbestosis, showing that, again, those risk factors, the immune-related and genetic background are associated to increase the risk for the prevalence of interstitial lung disease. And why some patients present with idiopathic pulmonary fibrosis and some of them present with some other diagnosis, we don't know that for sure yet.
Okay. I mean, perhaps looking at a penultimate question is, in families where there's been a history of pulmonary fibrosis, are there suggestions that if you do genetic testing, do you think you're in a position then to give suggestions on lifestyle changes that will be beneficial? Or will you not know enough about what those environmental triggers might be?
Okay, at least for smoking, it's quite easy to answer. And there are a lot of other risk factors. And I'll always talk about this family. And the child was a fireman. So it was really a hard discussion with him, discussing on how he should live and what he should avoid or not. But I think we need to have a discussion about lifestyle, whatever the patient and the family. So it's important. Yeah.
I mean, yeah, people with IPF often talk on themselves saying, what could I possibly have breathed in that caused it? And, you know, my personal list is about 10 different things, you know, that might have triggered it. We probably don't know.
Exactly.
Yeah.
We have too many culprits.
Great. The Greek group sent a wonderful long question from my friend there, unfortunately in Greek. And we'll have to give that one to you afterwards. But I think it's been a really excellent talk. Thank you both very much indeed for joining us this evening, and for stimulating such an interesting discussion. I think we don't yet, for me, there's a sense of that we may be on the cusp of really, that in 5 years' time, our understanding is going to be so much deeper and broader. We're going to understand most of the genetic mutations and variations involved. We're going to have done a lot of the analysis linking it to different diseases, different manifestations of pulmonary fibrosis. And we're probably going to be in a position in just a few years when genetic testing is really beneficial, and the associated counseling with it. Is that a fair assessment, or do you think?
I think so. For the last 5 years, we made so many improvements. So I think it's going to be like part of our practice in a near future.
Yeah. And we'll get to that personalized medicine that Coline had on one of her graphs, which is great. So thank you both very much indeed. It's a really fantastic contribution to our webinar series. Thank you very much indeed. And thanks also to the people who put in questions. It's clearly a great topic of interest to many of us. Over 100 people joined tonight, which is wonderful. Hope you enjoyed the evening and that you'll come to future events. Finally, I'd like to thank the EU-IPFF Secretariat team, excuse me, especially Samantha and Alba for their hard work in putting this on tonight. We've recorded the seminar, and so you can view it at your leisure, again, if you want. I wonder, Coline, could I ask you just to go back through your slides and put up the web link for the survey? 2 or 3 people said they wanted to see the web link. Okay.
There it is. Yeah.
That's a very long web link. I tell you what we'll do. We'll put it onto the EU-IPFF website tomorrow, Facebook and Twitter as well, so that you can do it again from there. So go to EU-IPFF tomorrow and you'll find that. And sorry, Coline, could you bring me back to the last slide again? As I said, the summit will be on the 23rd to the 25th of April. We have one more webinar before that. Dr. Marlies Wiesenberg from Erasmus University in Rotterdam, who is very well known to many people in the audience today, I know, is going to talk about optimizing quality of life in patients with pulmonary fibrosis. Yeah, we've so far in these webinars, we've had genetics tonight, we had side effects or comorbidities and the new non-IPF forms of pulmonary fibrosis. Last time with Michael Kreuter, before that Gisli spoke about COVID. This is an opportunity for us to talk a little bit more about symptom management and all of the other sides of living with the disease, which I'm sure will be of great interest to patients as well. So look forward to seeing you all on the 17th of March at the same time. And again, Raphaël and Coline, thanks very much indeed, yeah, for a very great evening. So good night, everyone, and have an enjoyable evening. Thank you.
All right.